Thanks for being with us this morning. The start of a pretty interesting weekend. I have this great background today because we are out in Lexington. We just kicked off the 250th celebration. So they just did the press conference to welcome everybody here. We have lots of revolutionary troops walking around. So it's just going to be a fun weekend, that coupled with the marathon. So I appreciate everybody taking time on this nice day to be with us. As members of the task force know, and for our guests, we begin every month by looking at our numbers. And we really are so fortunate in the progress we've made in this county, which is largely due to the collaboration of many, many people, but particularly people in our task force. And we talk every month about where we have been in terms of seeing opioid deaths across the county. And it's important to keep in mind the size of this county. As many of you know, Middlesex County is the largest county in New England. We have 1.8 million people, and we span 877 miles, 54 cities and towns. And while we certainly appreciate that even one death is too many, really because of the collaborative work that's happened here, we've seen real progress in terms of lowering those numbers. But we always think not just in terms of a life lost, but what that impact is. And if you think very conservatively of every life lost impacting 10 people, it gives a whole different shape to those numbers. So as we look this year, comparing to last year, in the period from January 1st of this year to today, we have seen in what has really been a remarkable change, only 29 fatal opioid overdose deaths across the county. And that is a 24% decrease from this same time last year, really because of the work happening here. And what I am really particularly pleased about is, and this is the first time this has happened, and many of you know, one of the things we've been talking about as we've made great progress in bringing the numbers down, what we have not been making such great progress with is those deaths by suicide from opioids. And keeping in mind, especially that our bar for our state police ruling something to be a death by suicide is very high. We have to have a note. We have to have some very clear declaration of what's happening. So even with that, our numbers have been on a pretty steady increase, excuse me. But I am particularly happy to report that this month we have seen almost a 50% decline in those deaths. So those deaths by opioids, which using our pretty high standard would be classified as a death by suicide, declined almost 50%. And that is very significant because we had not been able to turn the tide of that number. So as many of you are aware, individuals that are suffering from opioid use disorder frequently end up at the hospital for an overdose or for some other medical problem. And they are often folks who are being readmitted frequently to the hospital, which causes a real strain, both on the hospital and on the emergency service providers. Mass General Brigham doctors recently did a study that suggested that instead of looking at that hospitalization as just a drain in resources, that it could actually be a great opportunity for the initiation of treatment, including medication treatment and being referred to one of the addiction consult teams. Their analysis, which covered almost 20,000 admissions for patients with substance use disorder at Mass General Brigham hospitals, determined that patients who were able to see somebody from the addiction consult team were far more likely to start medication treatment and 18% less likely to be back in the hospital in the next 30 days. So almost a 20% reduction if they could get that. And those who got medication, who began medication treatment while they were at the hospital, were 54% less likely to be back at the hospital. And the problem is that we know from the Center for Disease Control that only about a quarter, 25% of Americans who need that treatment are getting the medication treatment they need. And connecting while they're in the hospital can be a really efficient way to do that. But the funding is very difficult, as it is in so many places right now. But at least 15 of our hospitals across Massachusetts have been able to use the opioid abatement funds to create or support those teams in their hospitals. And we're very fortunate about that. And I'm hoping that they continue to expand. And one of the interesting things that people have been talking about is that a way to address the cost of these programs is through AI. And Politico published an article last week that talked about how researchers at the University of Wisconsin Medical School were using AI to screen the health records of patients admitted to the Health University Hospital in Wisconsin for indication that that patient was either at risk of or had an opioid use disorder. And that model, scanning through the records, was able to send an alert to providers that the patient might be at risk and suggesting a referral to an addiction specialist. That just that screening process reduced readmissions. And they are estimating that doing that study saved over $100,000 because of the reduction in readmissions. So I think we sort of think of AI as being a threat in so many ways, and it clearly is. And we're clearly looking at a lot of crimes that are happening with AI, but this is an indication of how it could really be very useful. So I'm looking forward to hearing today about another way healthcare providers can be addressing gaps in addiction medicine. Dr. Sharon Levy and Takeaways from the Healing Community, which stands for Helping End Long-Term Addiction Study, from Dr. Stopka, his study, as well as learning about what our emergency medical personnel are seeing on the ground from John Kelly, who many of you know, who's presented a number of times. And we're going to begin with Dr. Sharon Levy, who is a pediatrician and addiction medicine specialist, the chief of the addiction medicine at Boston Children's Hospital, and a professor of pediatrics at Harvard Medical School. And Dr. Levy, over the past 20 years, has been evaluating and treating thousands of adolescents with substance use disorder. She's conducted research, she's written extensively on the topic, and in 2016, she established the nation's first accredited pediatric addiction medicine fellowship training program. And in 2023, she was appointed the chief of the first division of addiction medicine at a pediatric medical center in the United States. She has expertise in the integration of substance disorder treatment into pediatric primary care. And we know, and we've seen and talked about so many times here, how important it is for kids and younger teens to be able to get those kind of services. And Dr. Levy is joining us to talk about Boston Children's partnership with the Mass Child's Psychiatry Access Program. So, Doctor, thank you for being with us. We're looking forward to this morning.
Thank you very much. It's really my pleasure to be able to speak to the group. Such important work that's going on at so many levels. Today, my focus is a little bit different. It's much more in the field of prevention. We know that substance use addiction is really a chronic disorder with onset during the pediatric age range. And so identifying and addressing substance use in those early years really has the potential to bring benefits that accrue over a lifetime. I want to thank you for that lovely introduction. I do want to make one correction, and which, by the way, I wrote the introduction, so it's it's okay. But one minor correction: we didn't actually start the first accredited addiction medicine fellowship. We started the first accredited addiction medicine fellowship in pediatrics. So I just in case anybody just to be accurate, and because so many people have done so much work in this space, I don't want to take credit that doesn't belong to us. Okay, and I'm sharing my slides now. I hope that everybody can see them. I'm going to talk to you today about what we call Primary Care Plus, or for short PC Plus, which is really a MCPAP substance use program for pediatric primary care. So, here's the big idea. The big idea is that substance use starts for most people during adolescence, young adulthood. That treating it at that point actually can yield benefits that accrue over a long period of time. And that most kids who have substance use problems and disorders will never go to a substance use disorders program, nor will they ever see an addiction medicine specialist. There aren't enough of us, but even if there were enough, it's really hard to get young people to a substance use disorder program. Most young people who have substance use disorder programs don't think that they need treatment, don't feel as if they have a problem. So, we thought we could use the chronic disease model and really push the care for most substance use in adolescents into primary care. And this is really what we do for other problems. Most kids who have asthma are treated by their primary care provider, who will prescribe to them and follow them. Really, only the kids with the most severe or recalcitrant problems will ever see a pulmonologist or an allergist. Same is true for kids with ADHD. The majority of kids with ADHD will be treated in primary care. Those with the most tricky or non-responsive cases might see a developmental pediatrician or a psychiatrist. But the lion's share of care for all of these conditions is in primary care, and we need that to happen with substance use as well. And so our question became, how can we partner with our primary care colleagues to support the integration of substance use care into primary care? And so we designed this program that we call PC Plus. This is a graph, this is my iceberg. On the top of the iceberg, we have something called brief intervention, and folks who are familiar with the medical approach to substance use disorders in primary care probably have heard of the term called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. And most primary care docs will say the way you deal with substance use in primary care is through SBIRT. And so that means what their responsibility is really a brief intervention, which is in pediatrics usually a 2 or 3 minute conversation encouraging kids not to use substances. That's a great conversation, and actually it's been shown that moves the needle, that those conversations actually can reduce substance use. But it really is the tip of the iceberg in terms of what we can and should be doing, particularly for kids who've already really initiated and those who've already established substance use. We can be assessing and treating cravings. We know from national studies that 50% of the kids who vape nicotine would actually like to cut down or quit. But very few of them have anybody to turn to help them with medications that might help them suppress cravings, that might help alleviate withdrawal symptoms for that withdrawal period of a couple of weeks. Laboratory testing can be helpful. There's sort of medical counseling that goes beyond brief intervention. Most of this stuff we're simply not doing, even though all of it is really in the wheelhouse of primary care. So we started a program where we offer intensive support for primary care practices. This is a picture of Shannon Mountain Ray, who is our head LICSW, our head social worker who runs this program, showing her with one of our first practices. These two physicians, pediatricians here in Massachusetts, actually started treating kids with opioid use disorders right in their practice. They were prescribing buprenorphine with our support, and the Boston Globe covered that story. But basically, the intensive support really basically has two components. The first is MD to MD consultation. So this goes through the Massachusetts Child Psychiatry Access phone consultation line, the MCPAP program, where pediatricians or primary care providers, pediatric primary care providers can call and request a consult for any substance use question, right? So it could be as simple as, I have a young person who wants to quit vaping. Can you tell me how to use nicotine replacement? It gets more complicated over time. As folks get comfortable with those kinds of things, they start asking you more complicated questions. Like, I just saw a patient with moya moya. Is nicotine replacement safe in that case? More kinds of questions that you expect as a specialist as they that are really more specialized, more complicated. And so we've seen that happen over time. To back up to back up what the primary care providers do, we also offer virtual counseling. We have 8 or 9 counselors who are all available to see pediatric primary care patients. So, for example, if a pediatrician identifies a young person who is willing to cut down on their cannabis use, they can call us. We can give them support for how they might treat withdrawal symptoms, how they might use medications to suppress cravings, how they might use medications to treat anxiety in the patient. And then they can actually also refer to our counselors who will see these kids virtually. And the results of this have really been quite good. Not only have we been able to create a self-sustaining, revenue neutral program, but the average number, last time I looked, the average number of visits completed by kids who came to the service was somewhere between 7 and 8, which actually is a remarkable number. So it's not just a one and done. Kids who come, they come back. And so they're really engaging in these services. And then I want to just go over, this was data we looked at actually in 2021. We've published this, but I want to go over it because it gives you an idea of what we're seeing and what we're doing. So this was one of our very early years. We started actually some point in 2020. But between January and December of 2021, we completed 128 MD to MD consultations and 279 counseling appointments with a mean of 7.1 visits per patient. So these are the substances that pediatricians were calling about. Cannabis, not really surprisingly, far and away was number one. 64% of all calls were something to do with cannabis. If you put nicotine and vaping together, that becomes number 2, alcohol number 3, 5% of calls were about opioid use. And we know from our documentation that that included advice on how to treat opioid use disorders in pediatric primary care. So we really did go the whole spectrum. Here is the outcome of our 128 consultations. For nearly 70% of the kids, we recommended treatment right in primary care. Like, you write the prescription and our counselors will take care of, will support the patient. About 20% were referred to outpatient specialty treatment. That's our own outpatient program where we thought that patients were willing to be seen in a substance use disorders program and the problems were a little bit more complicated, where more services and a little bit more of a safety net would be helpful. And then 11% were referred to higher levels of care, mostly acute residential treatment. I also just wanted to show you that as part of this program, it's been very successful. We've been able to create a really robust group therapy program for adolescents with substance use disorder program. This is a sampling of the groups that we offer. As you can see, all different kinds of groups for kids with all different issues, interests, and willingness to participate. And the exciting new piece is that we are building, and we're in the process of building, an intensive outpatient program for young people who are actually well enough that they can still go to school, but need extra support in those after school hours. So they would come to a program that will operate from about 4 to 6 in the evening and get the support they need for a couple of extra weeks. This is a program that we hope will kick off in the fall. Actually want to stop there. This is our addiction medicine team at Children's. If you really loved what I had to say and are very interested in it, you can hear my audiobook, which is actually made for parents on how to talk to their kids about substance use. And I will stop there, and thank you very much for your attention, and happy to answer questions.
Thank you, Doctor. Questions, comments?
Hi.
Carol, do you have a question?
Yes. Thank you, Dr. Levy. Thank you, DA Ryan. Amazing work. May I ask for clarification? What age does the program go up to? Is it 21? Is it the,
Thank you for
the,
the question. Actually, the mandate of the program is to see patients who are in pediatric primary care. So it really, if you're being seen in a pediatric office, we can see you regardless of age. And we will, for some of the older kids who are transitioning from their pediatrician, we'll hold on to them a little bit longer to make sure that they kind of land in a medical setting before before transferring their substance use care.
okay. And thank you. And is this, and maybe I should have framed my question better. This is when you're working with the pediatric practice, with the virtual and the McPAP model.
Correct.
If someone goes to your center, yeah, because for many years we've referred people, Needham Public Health, to Children's, as you know.
Yeah. Yes. So the adolescent substance use and addiction program that we call ASAP at Children's Hospital, that's an outpatient substance use disorders program for young people. Um, we take patients before their 22nd birthday. So we're really the prime age group that we treat is actually 14 to 18. It's mostly the high school age range. We have no lower age limit, and we've fielded calls for kids as young as 8, sadly. And we've had patients as young as 11 or 12, not that infrequently. For older people, we will start them in treatment before their 22nd birthday. We think our services are kind of unique, and we like to make sure that it's one of the few places that younger people can really get care. So we really like to hold those spots for young people.
And when someone, it's primarily 14 to 18, but you could start someone before their 22nd birthday.
Correct. Patients can come in for an initial evaluation as long as they have not turned 22 yet. And then we will treat them. If they have come in for an intake, we will treat them until they've completed a course of treatment, even if they cross their 22nd birthday while they're with us.
Okay. And one more, thank you. And a few years ago, you were doing incredible work in giving people who need it medication for opioid. Is that still the case?
Oh, absolutely. We treat young people with opioid use disorders. Uh, we prescribe buprenorphine in all of its forms. So I think if that's the question, and again, I highlighted this is a much smaller part of the program, but in the PC Plus program, we also support pediatricians who would like to do that, and that comes up because some kids want injectable, and sometimes we even partner. It's a small number, but sometimes we even partner with pediatricians, right? So a young person who wants an injectable form of buprenorphine but lives in Western Mass. It's not really practical to come every month to Boston for an injection. So we might actually do some of the care virtually to support the person, but the injection can be given, at their local pediatrician.
Incredible. And thank you. And I appreciate always your commitment and talking and being willing to partner with all of us in prevention across the Commonwealth, Dr. Levy. And you always remind us about the age of onset for most people that develop a substance use disorder, and that prevention and the work that Mary and Ryan does and all these public health directors and prevention folks across the Commonwealth with you is deeply appreciated.
Thank you.
Other questions, comments?
I have a question.
Oh, you have a question, Director,
Um,
sorry.
Sure. That really amazing work, Dr. Levy. What you just said really caught my attention, just the interest in long-acting buprenorphine, extended release buprenorphine. You mentioned monthly, so I assume it's Sublocade or the monthly version of Brixadi. But I wonder if you could just comment a little bit more about that. We just published a paper on the huge uptick in prescription and treatment of folks seeking extended release buprenorphine across Massachusetts. But we focused on adults. So I'm curious to hear more about pediatric patients and their interest in the injectable buprenorphine.
Yeah, so it's not so the by far and away the most common problems we deal with are cannabis, alcohol, and nicotine. Like that's like numbers 1, 2, and 3. I think the numbers that I showed you reflect something like 5 or 10% of young people who come to our program have an opioid use disorder. Most of them are on some form of buprenorphine. I'll tell you that I think that the injectables are a hard sell, but we do have some proportion of the young people on buprenorphine products will use these injectables. And I'll tell you, they tend to be the young adults, like the older end of our age range, who go for the injectable versions.
Karen.
Hi, everybody. Karen Koretsky from the Arlington Prevention Coalition. And thank you, DA Ryan, and all my colleagues, and Dr. Levy. I've been a follower of your work for quite some time. In looking at that chart, it was not surprising that THC addiction tends to be the primary substance situation that you're seeing. Is that correct? I think you said it was 64%.
64% of the calls that came in from pediatricians, the primary substance that they had a question about was cannabis. If you look at the outpatient program, the numbers are much higher. These are not mutually exclusive, of course, but about 95% of the young people who come to our program for any reason will have a cannabis use disorder. So, for example, kids who come for treatment of opioid use disorders will often also have a cannabis use disorder.
Right. And so I wonder what is the recommended treatment for cannabis use disorder at this point? Is there one protocol that's sort of the gold standard? Because of course that seems to be the drug misused by students in our community, young people in our community.
Yeah, so I think we work with kids where they're at, and so I think a lot of the young people who show up to the substance use disorder program are willing to cut down or make a quit attempt, and for that group, I think following them for withdrawal symptoms is really critical, because I can't tell you how many young people have said, try to cut down, I can't sleep, or I can't eat, or I'm too irritable, or whatever the issue is. So we're doing a lot of screening for withdrawal symptoms and treating them symptomatically. For cannabis, it's a little bit longer than for nicotine, or other substances. It can go out several weeks. We offer kids a trial of N-acetylcysteine, or NAC, to suppress cravings, because there have been some studies that show that this is helpful in young people. I think that the evidence is there's some evidence. There have been at least 2 publications showing that young people who are treated with NAC used less cannabis at follow-up time points. That has never been repeated in adults. And what is unknown is does it just work better in kids? Like, I think that there are still some open questions, but we offer it to young people. A lot of them use it, and I would say it seems to be helpful some of the time. We offer kids counseling and emotional support. A lot of kids need skills in dealing with cravings and coping with stress and all kinds of things. The group therapy programs can be very, very helpful. A not insignificant proportion of kids who come to our clinic have psychotic symptoms. And so we're following them. We're deciding if they needed to be treated with antipsychotics for a period of time, in the hopes of preventing the development of a psychotic disorder. We see plenty of kids with cannabis hyperemesis syndrome. So we're not only seeing cannabis use disorder itself, but we're seeing the side effects that go along, particularly with these potent versions of THC. And so that's the kind of work that we do.
Thank you. Could you just cycle back and tell me the medication that suppressed cravings is called what?
N-acetylcysteine, NAC, which is actually something that's available over the counter. And for medical folks on the call, it is the same thing that we use to treat a Tylenol overdose, right? It's got some hepatoprotective kinds of qualities, but there's some, it turns off the cyclic GMP protein it's been shown to, that theoretically you could understand the link of why it might reduce cravings. And like I said, 2 studies published out of South Carolina show that it did, and anecdotally, we have some kids who have good results.
Any other questions, comments? Doctor, thank you. Just amazing work, and clearly something that applies to so many folks. Thank you.
My pleasure. Thank you.
Now we're going to turn to someone that regular members of this task force know well, John Kelly. John is the Director of Communications and IT for Pride Star Trinity EMS. And John and his coworkers provide 911 services for 7 communities. John leads the only ACE accredited dispatch center in Massachusetts, and he leads the Pride Star EMS data assistance efforts. And we've seen many, many times, John and his crew have done just such a deep dive in being able to tell us so many helpful things about when things occur, days of the week, times of the day, periods of the year, that have really helped us to shape our work here, and has also helped EMS and public health agencies across the county in shaping their programs, from things as simple as when to put water out or when to be ready on the streets for certain things. John's just been a mainstay of this task force with some great work. So John today is going to talk about the 2024 report for calls to which Pride Star was dispatched in the Lowell area. So thanks, John.
Thank you very much. I appreciate the opportunity to be here. Can everybody see that? I just want to make sure before I start rambling on. All right, awesome. Thank you so much. So last year in Lowell, we saw, just going along with the DA's numbers that she's seen the decrease, we had a 26% decrease in non-fatal overdoses last year in Lowell versus the year before. So last year in Lowell, we had 460, which is dramatically down from our peak, which we'll show you in a little bit, but a huge reduction in non-fatal overdoses. Now, there was also a reduction in fatal overdoses as well. So it's not like one went down and the other went up. That's the lowest total we've seen since 2013. So think, the idea was that in 2014, fentanyl showed up in our communities up here in the Merrimack Valley. We went through kind of the peak in 2018 through the pandemic and everything else. So we're back to the numbers that we saw in 2013. The numbers were, there was a couple months, the numbers were so low, like we actually thought we screwed up the data. We went back and we said, okay, we've changed something. We've done something wrong. I got a panic call on a Sunday night. Hey, we did something wrong, but we haven't figured it out quite yet, if there is anything. And then last year, just in Lowell, we took care of patients from all these Middlesex communities. So someone from Ashland came up to Lowell and we took care of them for having an opiate-related overdose. Again, we don't provide service in Ashland. We didn't go there and pick up their patients, but again, these are the communities represented in our data set for last year. So for the next 15 minutes or so, we're going to kind of go through kind of a little bit more about the EMS data, where it comes from. And because I think EMS data is very underutilized. There's a lot of it out there. We're going to go kind of over what we saw last year and then kind of finish it up. We'll take a longer journey look at kind of the bigger picture on information. So I don't work for the city of Lowell, and I don't speak for them. And these are all non-fatal 911 calls. So our data comes from our patient care reports, right? So every ambulance, you have an interaction, you have to create a patient care report. Our data set has about 1 million points of data in it. That information could be something as simple as the patient's age, or it could be something as complex as a 500-word story about the patient with the interaction with the patient. So it's just a massive data set. It's about 16,500 calls. And there's really nothing unique about what we do. Nemesis is the the information system that all ambulance services are required to have. So whether you're fire-based, police-based, hospital-based, we all have the same requirements. So everybody has the same data. It's just a matter of, can they figure out a way to get it and then present it? And then for us, we have two paths for how we gather our data. So we have an automated system from a company called First Watch. They touch 1 out of every 2 911 calls in America. So basically it automatically reads our patient care reports. And then if it's like if-then statements, right? If this is found, then do this. So it looks for opiate, opium, Narcan, Narcane, because sometimes we spell things wrong. And it says, okay, if any of these conditions are met, notify these people, right? So for us, when there's an overdose in Lowell, some of us that are in the HIPAA bubble, right, we'll get a text alert, an app alert, or an email that contains the entire patient care report, patient name, and the story about what happened on the call. People outside the HIPAA bubble, but are still related to the task at hand, they'll get notification, but like we can't share with the police the address. We can't share with the police the patient information, right? We still have to think about the patient as a patient. So they'll get notification, but it's limited. And then the other one is our manual process. So that's the data set of 1 million points. So we have someone who's read every single one of those 16,500 patient care reports, and he goes in and he adds a lot of value. So he'll figure out, is the overdose in a public space or a private space? Who gave Narcan? You know, that sort of thing. So we try to create a rich data set. And then we try to use that data set to help with grants, right? So Lowell's got a great co-op team that our data helps support their mission. And at the beginning of it, try to, show the systems in place and the impact on our communities. Dr. Tom's coming up next, and we've done a bunch of studies with him over the years. I think back to that meeting in 2016, I should have walked away, but I'm only kidding. So we have a bunch of studies with First Watch, the CDC, APHA, and the Tufts School of Medicine. We're working on one right now that I don't know if that's what he's going to talk about next, but trying to use machine learning to replicate what we do manually. So the data scientists and geniuses at Tufts, they use all sorts of big words. I don't know what half of them mean. I just kind of smile, but they've figured out a way to kind of get machines to do what our person does, right? Because our problem, it doesn't scale, right? We can do our system, but we couldn't do everybody else's. But with this machine learning element of things, right, we can start to use, we can start to expand it a little bit. Also, our tools, we, like the DA was saying, we can provide hour by hour what's happening, right? We talked, the can of Pepsi, right? You get a can of Pepsi today in Lowell, Massachusetts. You buy one in Lowell, Michigan tomorrow. It's the exact same. You could buy heroin today from a dealer in Lowell, and 2 hours from now go back and buy the same thing, and it's a completely different drug. And that's why you have so many, surges in overdoses, and it changes. And then also our data set going back to 2011, it allows us to have a kind of a long-term look at what's been happening in our communities. So one of the things we do every month for 4 of our communities, we produce this report here. So it just went out this morning. It has about 17 points of data, and the data can be expanded for just the last 30 days. It can show the last year, and that can also show the last decade. So, there's a whole bunch of different information in there. And again, most of this data was requested by different grants along the way. So kind of highlighting it, the results that we found. So 71% of our overdoses in Lowell happen in the public space, right? So an overdose happening in a private home from a public health standpoint has a different impact on the community than it would one in a park, right? And when we look at our information, our smaller communities are, 30, 40, 50,000 person community, most of those overdoses happen in private homes, right? So when you're trying to do outreach and you're trying to get Narcan in the hands of people, if overdoses are happening outside, it's easier to get Narcan into those people's hands than a specific household. And then in Lowell, one of the things we found is, 65% of our overdoses happen in just 2 neighborhoods. And then we have 6 neighborhoods where they had fewer than 20, right? So it's a very geographic based as well. So we're going to look the next couple of minutes, just talk about 2024 specifically. So those are our totals by month. So you can see we had a high of 60 down to just 19, right? So it's not consistent at all. There is a seasonality to it. that we've found over the years, and we'll talk a little bit more about that later. It was that, that 19 in October and September was really when we had the panic attack, like, uh-oh, what did we do wrong? Did our patient care reporting system break? Did we suddenly create new ways to spell, heroin? So that's kind of our totals. Our max, just as a point of reference, is that June of 2018 with 99. So this is a subset of our patients. So these are the patients that in that overdose set, right? So not every patient we interact with for an opiate is an overdose to the point where they need Narcan. So these are our Narcan totals. So we had 47 1 month and 9 down in December, right? So again, no consistency in the numbers. It kind of just massive disparity in the data. Kind of the interesting thing is our max, as you can see right there, was September of 17. So even though the totals have fallen off quite a bit, we still came close to that peak for the Narcan needs. And I think that's probably, I think part of the decrease is the availability of Narcan. I do think there's people that are overdosing that are not seeking help. And obviously the outreach and the treatment options, right? You think back to 2014 and in the places and options for people to get treatment is drastically less than what we have today in place. So kind of summarizing last year's stuff. So we took care of people from 37 different communities that came into just Lowell for us. We had 340 different people. So the 460 events, we had 340 different people. We had 299 instances of a patient needing Narcan to be saved, and that was spread about amongst 225 different people. So think about it. If every overdose was fatal, Lowell would have had 225 additional deaths last year from overdoses. And we had 5 patients that we interacted with 5 times. So again, there are a vast number, but even within that, we have some kind of super users that are saved quite a bit. I think, I think the biggest, most important piece of information in this whole thing is right here. So last year, right, of our 299 events, 44 doses of Narcan, the first dose of Narcan was given by a bystander, right? So before police, fire, EMS shows up, somebody has already started to provide that life-saving measure. And that comes back to the great work from the city of Lowell, right? The co-op team, Lowell House. I'm going to forget everybody. I apologize, but the Leave Behind Narcan program. I mean, the DA supplying all these agencies with that Narcan. Without this, right? Without this 44% getting that first dose before anybody gets there certainly would have been more deaths. So it's really a credit to the entire community and, ownership, acceptance, and working on solutions and not blame. So it's really an impressive piece of information. And I think the first time we reported this was 2018, and it was about 30%. So it's definitely increasing over time. So we're going to talk Lowell over the years a little bit. So we'll go 11 to 15. Again, we kind of go through these a little bit quick. So there's our annual totals over the last 5,114 days, in case anybody's double checking me. At least that's what the Google said. You can kind of see our journey up from, a low of 190 up through everything. And then we kind of put a couple different markers on the way here. So 2012, we got Narcan in the BLS trucks in Lowell as part of a special project waiver. 2 years later, the state put it on all the trucks, which is kind of when fentanyl was thought to be shown up in the area. We had our peak in 2018, kind of through the pandemic, right? And then the Leave Behind Narcan program, which actually was assisted by the Healing Community Study. So when the protocol first came out by OEMS, it was really written for Boston. And it was if the patient didn't go to the hospital, you could give them Narcan to leave. Like you could leave them with Narcan and they could walk away with it. But for us, our patients all go to the hospital, right? 96% of them are going to the hospital. So there was very few opportunities for us to leave behind Narcan. It happened to be during the Healing Community Study. So we had a couple conversations with the Boston Medical Center chief medical directors and kind of explained the situation and said, hey, DPH is going to listen to you, not me. And it was honestly, it was like 100 hours and they changed the protocol. So it was, kind of a collaboration and great effort by, behalf of the Healing Community Study. And then one of the other things we were talking about, the last section was talking about was buprenorphine, right? So Mass OEMS has actually changed the protocol as of a year ago that ambulance services in Massachusetts can give buprenorphine pre-hospital, right? So there's been a couple studies out of Cooper Medical Center down in New Jersey that show the same sort of data, right? If you can get people buprenorphine, they're more apt to show up at their next appointments. Did someone have something to say? Oh, okay. So this kind of our totals. Oh, I got the wrong computer going. Again, kind of summarizing it here. In that span, we've taken care of 3,800 different people. 3,000 of them are Middlesex County residents. We took care of people from 120 different communities. And then this next slide is going to get a little confusing. It took me a little bit. It took me a little bit to figure out how to get it even this clear. So stick with me here for a second. So basically for the last decade, okay, every other day in Lowell, we've interacted with somebody for the first time that was found to be in respiratory arrest because of an overdose, right? So you're talking 5,000 days, 2,500 different people. So really if you do out the math a little bit, right? Basically every other day we've met someone new that needed to be saved. Wrong computer again. And then kind of my last slide here. So just kind of little tidbits of the information. So our highest day, we had 10 overdoses in one day back in 2016. We've had over 825 different days with at least 5 overdoses in our communities. And the next couple slides, like you could start to kind of use the EMS data to get some intelligence as to kind of where and when outreach needs to happen, right? So most of the overdoses kind of 3 to 9 at night. The day of the week didn't really seem to matter much. We have a 100-day span between, including June, July, and August, and a couple days on either end, where I think it was like 47% of all the overdoses we do annually are just in those 100 days, right? So if you kind of use that, you can start to, kind of draw like, okay, when is the best time to do outreach? And then finally, in all of our communities, right? So we do the 7 communities now. So we've taken care of 6,500 unique people, of which, so we've had 4,600 different people in respiratory arrest because of an opiate in one of our ambulances in that 5,000 days. So that's really my presentation. There's my email. If anybody, usually after these, a couple of people kind of send emails. We're happy to help in any way we can. If you're fire, EMS, public health, if you're looking for a little bit more, information or how we do it, obviously it would be difficult, if not impossible, to go back to 2011, right? But that doesn't mean we don't try to kind of start today. So I appreciate the opportunity. Does anybody have any questions?
Thanks, John. Carol.
Thank you, John. Every time I hear you, I learn more. What I'm wondering, how can you ask as a Board of Health member or as a public health person easily without stressing your local EMS? And, yeah, I'm going to stop there. For data, we have grants and we continue to apply for grants and funding from foundation across the 5 towns I work with.
Hold on. I think you really probably need to find a champion within the EMS that would lead that up for you. If you have, honestly, if you have a private ambulance service, you could just tell them, like that, we got a call. So this is how we got into it. So we got a call from the Lowell city manager. It was Kevin Murphy at the time, 2016. And he said, hey, you have to get more involved in this. And we said, okay. And then we started going to meetings, and then we just, we just thought we were in a unique position because of EMS, because, the hospital can tell you how many overdoses that came through the door, but they can't tell you when and where they happened, right? But we can. We're the only ones who have that information. If you can find someone in your fire service that, can be your champion, maybe they have a family tied to it. Like Lowell Fire, if you go back to, Kevin Jones, for everybody that remembers him, he was the Railers co-op guy. You know, he was all in. Everything was co-op for him, and there was nothing he wouldn't do for these patients. And then maybe you just got to find a champion in that 5-town collaborative that can, it's really not that hard, to be honest with you, right? It's difficult to start up. So if you find that champion, we're happy to kind of, like, there's nothing secret we're doing. We'll give everything in our entire process, right? There might be some technology issues, like if your ambulance services don't own their data, right? If you just create a patient care report and all the town can get is a PDF, that makes it more difficult, where we own the individual cells, so we can export it into Excel. So that might be a technology hurdle.
Okay. And you did mention, and you've said this before to educate us, it's a federal requirement to collect NEMSIS. Each community has to on a call. So the data is there. We have a hospital in one of our towns, and many of the staff will tell us alcohol, is the primary issue. I mean, so we've talked about being able to sort not only, by various substances. And
I don't work for them, but I work with them a lot. So there's a company called First Watch, right? And I talked about them a little bit. They touch 1 out of every 2 911 calls in America. So, if you've got grant money, right, they can get in between the fire department. Your ambulance provider really wouldn't have to do anything, right? They continually do what they're doing. And then when it gets, so there's something called a state extract, right? It's NEMSIS, it goes into TEMSIS, which is the Massachusetts system. And they can get in between those. So the fire department almost doesn't even, they would know it's happening, right? But they wouldn't have to do anything different. And that First Watch tool could get in between and extract whatever you wanted it to. So if you wanted to know, people over 50 that break their ankle on Thursday mornings, right? That's how absurdly specific it can get.
last question, is that, so First Watch, you said, scans 1 of every 2 911 calls. That's like a federal law or something?
No, it's just clients like us. So we have it, right? And it reads every single one of our patient care reports. NYFD has it, and LA County, Miami. So it's completely an add-on for whatever community.
Okay.
Like Pro EMS in Cambridge has it. So they read every one of theirs. So.
And then the manual part. I appreciated your graph. Okay, so thank you for giving your email. Thank you for answering the questions. The data is so valuable to us in
If
public
you come up
health.
with any other questions, please reach out again. No problem.
Thank you.
Sure.
Any other, excuse me, questions, comments? Okay. John, thank you. Thank you for being
Thank
with
you.
us again. Turning to Dr. Stopka, who is an epidemiologist and a professor with the Department of Public Health and Community Medicine at Tufts, one of the Tufts geniuses, I'm sure. Dr. Stopka's current research, which is mixed methods and community engaged, focuses on the intersection of substance use disorder, infectious diseases, and opioid overdoses. He uses geographic information systems, spatial, epidemiological, qualitative, and biostatistical approaches to doing an interdisciplinary study and a public health intervention to better understand opioid-related morbidity and mortality. He is currently a multiple principal investigator on 4 clinical trials and observational studies that are being funded by federal agencies, and we hope will continue. Dr. Stopka is also co-chair of the Tufts Research Cluster, focused on equity in health, wealth, and civic engagement. And he serves as the co-chair of the Public Health and Community Medicine Departmental Research Committee at Tufts. He teaches courses in geographic information systems and spatial epidemiology, research methods for public health and epidemiology. So, Doctor, thank you for being with us this morning.
My pleasure. Thanks very much, DA Ryan, for the invitation, and to Emily for helping to get us all set up. John Kelly is a hard act to follow, so I'll do my best. And John's been an amazing collaborator over these past 10 years. So grateful for all the work we've been able to do together in Lowell. And one of the geniuses is Olivia Lewis. She's here joining us. She's on my research team and does lots of the GIS mapping of data for our team. Also, Dr. Shikar Shrestha, who's leading up the study that John was alluding to, which is the one where we're using Trinity MS and machine learning approaches to better assess opioid-related incidents. So today I will focus on the Healing Community Study, 10 million people, 67 communities. And I'm just one of many, many people who have collaborated on this. I present members of my Tufts team. We really oversaw and I led the GIS mapping, risk mapping, and spatial analyses for our Massachusetts work and some of our collaborative work with the other states, Kentucky, Ohio, and New York. Dr. Jeffrey Samet is the principal investigator at Boston Medical Center, and you may know some of the key addiction medicine and general medicine docs and researchers like Mark LaRochelle and Dr. Alex Wally, and others. And there are dozens of others collaborators across Massachusetts and across the other states who have collaborated. I will show you some of the maps that we've created, particularly for Lowell as it relates to the Healing Community Study. And I just want to make sure and share what we always share as a sensitivity notice, that the points on the map that we show, they represent so much more than data points, right? They represent loved ones, family members, friends, coworkers, and peers who were lost to an opioid overdose. And with respect to confidentiality for their families and neighbors, we jitter or we geomask the exact locations of decedent residences. So always want to make sure to highlight that. So by way of background, John presented it for Lowell. In general, across the US, we've seen a tenfold increase in overdose mortality from 8,000 in 1999 to more than 80,000 in 2022. And the US Surgeon General and National Academy of Medicine have urged medical professionals to address the opioid crisis through advocacy, stigma reduction, uptake of opioid use disorder treatment, safer opioid prescribing, and evidence-based practices. I'll talk a lot about evidence-based practices, or EBPs, throughout this presentation. So around that time, the National Institutes of Health, National Institute on Drug Abuse, came out with a request for applications, an RFA, that ultimately led to the funding of Massachusetts and the other 3 states that participated in the Healing Community Study. As DA Ryan referred to, HEAL stands for Helping to End Addiction Long-Term. So the Healing Community Study overall goal was really to reduce opioid overdose deaths through implementation of evidence-based practices, including OE&D, MOUD, and to increase safer opioid prescribing and dispensing practices. These are the 4 states that I alluded to and the 67 communities. In the other states, there were largely counties that were the intervention and control communities. In Massachusetts, there were municipalities or groups of municipalities. And as many of you know, Lowell was one of the urban intervention communities, or Wave 1 communities. But there were 16 communities overall, 8 in Wave 1, intervention communities, 8 in Wave 2, control communities. They ultimately also received the intervention. I won't go through this in detail, but just to really highlight that, this was a randomized clinical control where the communities were the subjects. And we had 16 Wave 1 communities, 16 Wave 2 communities, or control communities. You see that in 2020, the intervention began in the intervention communities. And then the usual care was provided in the control communities. And we had this comparison period between 2021 and 2022, where we compared outcomes across the intervention and control communities. But then in 2022, 2023, the control communities received the intervention. So at a little later time point, but they received the intervention as well. So I want to highlight the context that we were dealing with, right? Around the time the study began. The intervention began in 2020. And you may remember something called the COVID pandemic, right? That began 3 months later in March of 2020, when we saw again a precipitous increase in opioid mortality across the US and in Massachusetts. And while this was happening, we're trying to implement evidence-based practices and ultimately get to this comparison period where we compare the intervention and control communities. So a very challenging context in which to start up a study. But the overall intervention is called the CTH, or the Communities That Heal intervention, and its three components were community engagement, opioid reduction continuum of care approach, or the ORCA. This is a menu of interventions people could choose from and modify, and then community-based health communications campaigns. But the overall goal was really to increase awareness and adoption of evidence-based practices to save lives. And many of you on this call may have been involved with some of the community engagement and community coalitions across HCS, or the Healing Communities Study. In Kentucky and Ohio, they used existing coalitions. In Massachusetts and New York, we built coalitions under the leadership of Dr. Jeffrey Samet and his team at VMC. The community coalition's goals were really to examine data, select evidence-based practices, identify partner organizations, and implement EBPs and monitor progress. And the communities received quite large amounts of funding that varied by state. Some of the key participating groups included the coalition, an anchor agency, a fiscal agent, community organizations, Massachusetts Department of Public Health, Community Advisory Board, and Boston Medical Center. And the community coalitions, in terms of their infrastructure, typically were comprised of 25 to 40 members. So each of the 16 communities involved in the study had a community coalition with leadership and a wide range of experts from different areas and domains. And their responsibilities on the right-hand side were to serve on the coalition, conduct community needs assessments, and to use data-driven selection and implementation of evidence-based practices. These are the different steps of the process, the community engagement process. And where we came into play, our Tufts team, was largely when it came to the community profiles and data dashboards to try to produce information and maps and data that could help to inform community coalition decision-making. There was also a large community advisory board that spanned the entire study and had representation from people across the state. And they advised on study design, opioid trends, equity, and implementation. They provided, or these are some examples of the people who were involved in terms of their expertise. And the CABs provided an opportunity to align academic healthcare research with needs and vision of the community, right? It's not a top-down approach. It was a bottom-up and top-down and in-between approach, where experts in the field could help to inform the work along the way. Our Tufts Geographic Information System, our GIS mapping and spatial analyses, aim to inform community coalitions, to inform selection of evidence-based interventions, and to inform local targeting of interventions across geographies. One of our papers, led by one of my team members and former student, Dr. Jennifer Putz, helped to assess applied risk mapping and spatial analysis of address level decedent data, so fatal overdose data, to inform opioid overdose interventions. And the maps took on many shapes and forms, and some of you involved in the work in Lowell, may have seen maps like these, where we highlighted the fatal overdose locations by race and ethnicity, for instance, the blue dots representing white non-Hispanic decedents, the blue dots representing, the yellow dots representing Hispanic, Latino, or Latinx decedents. And we also were able to characterize the overdose deaths by where they happened. John really focused in his presentation about how many overdoses happen in the community. And more than half of the overdoses happen in the decedent's home, in their own home. Those are the red house symbols that you see. A large number of others, the blue houses or blue symbols, happened in somebody else's home. Others were recorded in hospitals. That might be a bit misleading because the person was transported to the hospital. Oftentimes the overdoses happened in the local community. But we also juxtapose these data with the purple triangles, which represent encampments across the city of Lowell. And these data are from 2019 to 2021. So it's old compared to John's data, but we produced these maps when the community coalitions we're meeting and trying to make decisions. And apart from showing the spatial distribution of fatal overdoses across the city, we also calculate descriptive statistics to look at the counts and the proportions of overdoses. And in more recent years, 2021, we saw more overdoses and higher proportions of overdoses, the blue squares, among Black and African American community members in the city. We also relied on Pride Star Trinity EMS data from John's group. This is a map that shows opioid-related incidents, likely non-fatal overdoses. And here we highlight fatal overdoses and start to look at a little bit more of maybe the clustering that's happening across neighborhoods. And, you know, Acre, Lower Highlands, Back Central, Lower Belvedere neighborhoods come to the fore. You know, Lower Belvedere and the 70 circle with 70 in the west, those are where the hospitals are. So just keep that in mind. May not be where the overdoses happened, but where they were recorded. We also, because we're able to work with address level data, we can create heat maps. So we can look at the density of fatal opioid related overdoses per square mile. And we can overlay on those maps where there are local treatment centers available or facilities available, where there are harm reduction agencies and other services. And we could calculate hotspots. We can determine where there were statistically significant clusters of overdoses across the city. Sometimes local public health and state public health planners can better hang their hat on analyses in a map that is based on a statistical test. You know, where were the hotspots? We also looked descriptively at not only Lowell, but all of the other Wave 1 communities in terms of where fatal overdoses took place. And Lowell, in this purple, this is representing fatal overdoses that happened at the decedent's residence. 54% in Lowell happened at the decedent's residence, which was second only to Gloucester in terms of the percentage of overdoses that happened in the home. So in some of the more sophisticated spatial epidemiological analyses that we did, we try to take into consideration the description and examination of overdose disease and its geographic variations. You know, that where you're born, where you live, where you work, where you go to school and play, where you recreate, commute, and eat, like these things can impact health outcomes, and upwards of 85% of health data have a spatial component. And through spatial epidemiology, we try to tease apart these relationships. And we did this to better understand overdose and access to treatment services. And my colleague, Dr. Seeker Shrestha, led this study in which we tried to better assess buprenorphine treatment accessibility. And we use an approach where we're able to look at the number of providers, those are the black dots on this map, in our numerator, but the people at risk in our denominator, and then a search radius to think about, the distances traveled to get to treatment. But ultimately, we're able to calculate an index. And you can see where there's darker shading of green, there was higher index of accessibility to buprenorphine. And we can see the Merrimack Valley in the north, where there are a number of providers, but the denominator is also big in terms of the demand and in terms of the need. So the shading's a little bit lighter. So the accessibility index shows a little lower accessibility to buprenorphine, at least during these years that we were conducting the analyses, 2020 to 2022, during the HCS study. We also assessed access to overdose education and naloxone distribution in opioid treatment programs or methadone clinics. And one of our med students, Josh Parbs, now Dr. Josh Parbs, helped to lead these analyses in focusing on trying to optimize the positioning of harm reduction services. He focused on overdose education and naloxone distribution. In some of our more recent work, we focused on access to OTPs or access to methadone clinics. This is the greater Boston area, right? And so the green squares represent existing OTPs. The red circles represent fatal overdose locations. And what you see is that we're able to model those data and we're able to determine where are the greatest unmet needs. These are the purple or pink circles. Where would we recommend that new OTPs be placed to help fill gaps in current services based on a 30-minute walk time. And we can do this for 15-minute walk times. We can do it for 50 and 30-minute walk times. This is a 30-minute walk time. We've looked more comprehensively recently in a report we did for Governor Maura Healey and with the Bureau of Substance Addiction Services at MDPH at OTPs across the state. And Olivia, who's here on the call, created many of these maps. And we also can calculate based on street networks, walk times and drive times to OTPs. And in doing so, we found that only 13% of Massachusetts residents lived within a 15-minute walk of an OTP. And so these types of analyses help to inform decision-making for the Healing Community Study, community coalitions. My colleague, Dr. Sumita Srinivasan, also faculty here at Tufts, she focused on industries and employment industries to try to look at those industries that are at highest risk for overdose across Massachusetts and Kentucky, one of our key collaborators. And she found that workers in the construction industry were most affected with the highest number of fatalities in Kentucky and Massachusetts, both before and after the COVID emergency declaration days. We wanted to see how things changed after the onset of the pandemic. She also found that the number of overdose deaths in many of the at-risk industries increased, including accommodation and food services, arts, entertainment, and recreation, agriculture and forestry, fishing, hunting, and manufacturing, right? And we know that fishing's big, particularly along the eastern coast of Massachusetts, and a hard-hit community of employees. I talked about the ORCA, right? This is the Opioid Overdose Reduction Continuum of Care. We produced, right, those maps and spatial analyses, and we shared those with community coalitions. With hopes that it could help to inform their decision-making in terms of choosing from the menu of strategies that were available from the ORCA, and thinking about the range of different EBPs, overdose education, naloxone distribution, medication for opioid use disorder in the form of buprenorphine and methadone, for instance, and safer opioid prescribing dispensing. And the implementation settings vary, right? They could be situated within health and public health agencies, within criminal justice agencies, and within behavioral health organizations. All the while, communications campaigns were developed by the different community coalitions and across the state. And they focused on topics like naloxone, MOUD, and retention on MOUD. But the overall goals were to increase adoption of evidence-based practices and to reduce stigma. And there were a range of different audiences and target audiences. And these communications campaigns took on many shapes and sizes across the 4 states, including public service announcements on television, including billboards, signs on buses, signs at bus kiosks or waiting locations, and so on and so forth. Now, in terms of the randomized clinical trial, right? The overall outcome was the number of overdose deaths among adults, so 18 years of age and older. The secondary outcomes included OAND distribution, medications for opioid use disorder, total overdose deaths, and non-fatal overdose events. And I'll share some of the findings from the study. But you can see the range of evidence-based strategies selected for the randomized clinical trial and the intervention communities. There were 806 total strategies, and they took on different shapes and sizes for OEND, for MOUD, and for safer prescribing and dispensing interventions. Now, right, I gave that trend line previously of overdose across the COVID pandemic, right? Basically, largely due to the COVID pandemic, but the short term within which the study had to be implemented, evidence-based practices that were implemented prior to the comparison period. Only 38% of strategies were implemented prior to the beginning of the comparison period, right? So that's not good from your study design. You want to have the interventions in place when you're starting to compare your intervention versus your control communities. But COVID and other hurdles got in the way. And you can see the breakdown in terms of this is now strategy implemented by June 30th, 2022, which is the end of the comparison period. We're comparing intervention to control communities across Massachusetts and the other states. and still less than 80% implemented for OEND, 70% for MOUD, just under 80% for safer prescription strategies. So those are challenges. Let's look at OEND and our overall research question. We aimed to determine whether communities implementing the Communities That Heal intervention had higher rates of overdose education and naloxone distribution, right? John focused on the increasing rates of naloxone distribution in Lowell in recent years and how that has had an impact on reducing overdose. Here are some examples of how naloxone was distributed through different models, like paying people who use drugs to hand out naloxone in their social networks, EMT, the Trinity EMSs of the world, for leave behind programming or leave behind naloxone, community sites and outreach, naloxone cabinets. Some of you may recognize Gary Langis, one of our harm reduction forefathers here in Massachusetts. And then naloxone distribution rates. Here's good news, and John alluded to this too. We saw a 79% increase in total naloxone distributed. The lighter purple represents intervention communities, so that's the higher bar. The darker purple represents the control communities. And within community program distribution, like the Leave Behind program, we saw a doubling in naloxone distribution, 104% increase in intervention versus control. In terms of pharmacy distributed naloxone, we did not see a difference. Let's talk about MOUD. The research question was, did the communities implementing the CTH intervention have higher rates of MOUD initiation or retention? And here are some examples of the MOUD strategies: expanding treatment locations and hours, trying to improve linkage programs, providing retention support like through retention coordinators, and reducing barriers to MOUD, for instance, through PT1, right, and other transportation-like programs. So we found, unfortunately, however, that the communities that received the intervention did not have higher rates of MOUD receipt. In fact, they decreased a little bit, not statistically, but they decreased a little bit in the intervention compared to the control communities. Keep in mind, this was happening during the COVID, really the height of the COVID pandemic. So that may have limited folks' ability to get to their treatment programs until telemedicine became more prominent. In terms of the primary outcome, opioid overdose deaths, we aim to compare the number of opioid overdose deaths in adults during the comparison period between the intervention and control communities. And when you see something like a rate ratio, less than 1 means there were fewer deaths in the intervention communities. This was published recently in the New England Journal of Medicine, if you want to read more about the study in details, and there was probably over 100 co-authors of us involved with that paper. While, the rate ratio went in the right direction, we did not see a statistically significant difference between the intervention and control arms in terms of fatal opioid overdoses. We did look at total overdose deaths, so both fatal and non-fatal. We did not see a statistically significant difference between intervention and control communities. We looked next at non-fatal overdose events alone. And here we did see a positive outcome. We did see that there was a 15% difference. So 15% lower non-fatal overdose rates in the intervention communities in light purple compared to the control communities. And you can see that that was largely driven by Massachusetts and New York, where we saw considerably lower non-fatal overdose risks in rates in the intervention versus control arms. So those are the main findings, but let's talk about some of the limitations and caveats to this study. There was a complex array of strategies for high-risk populations in healthcare, behavioral health, and criminal legal sectors. Not enough time for implementation of the evidence-based practices to achieve full benefit for reducing overdose fatalities. Pandemic and the demands on community coalition members, clinicians, public health officials, healthcare personnel were huge at that time. This was another hat that they were trying to wear in the midst of a 100-year pandemic. Increasing fentanyl, of course, in the drug supply is a major challenge, and that it started to also contaminate the stimulant drug supply. We had 4 states and 67 communities. If we had more states and more communities, perhaps we would have had more statistical power to see more meaningful and significant changes. Other HCS results. We did have an example of overdose education, naloxone distribution in terms of peer stipending. And we found that the annual coverage of 100 to 250 naloxone kits per 100,000 residents was associated with a 46% reduction of opioid overdose death rate. And places like Holyoke reached 109 kits per 100,000 population. Gloucester, 222 kits per 100,000 population. As John alluded to previously, the Leave Behind program in Lowell greatly increased access to naloxone, getting it into the hands of people who could most readily use it. That 40% statistic you showed, John, in terms of the percentage of ORIs that were responded to by a community member, that's huge. And the peers receive weekly stipends for $25 to $125 per week. So that's not a huge amount of money to make this happen. So providing cash stipends to peers, excuse me, providing cash stipends to peers is feasible and expanded OE&D. In terms of stigma, intervention community coalitions reported a larger decrease in perceived stigma towards people treated with OUD and towards MOUD treatment in the control community coalition members, or then in the control community coalitions. There was no difference in stigma towards naloxone in intervention and control communities, but overall, the communities that heal intervention holds potential to decrease OUD stigma in diverse settings nationally. So in conclusion, the opioid overdose deaths in intervention and control communities, we did not see a difference, unfortunately. Non-fatal overdose, we did see a 15% reduction in the intervention versus control communities. Naloxone availability increased 79% overall and over 100% through community-based distribution. MOUD treatment options did not increase, or let's say MOUD treatment initiation and retention did not increase. Stigma was reduced regarding MOUD treatment. And some of the mitigating factors were the COVID pandemic, as well as the complexity of the many different evidence-based interventions and insufficient time to implement them. So some other take-home messages. The community that heals intervention provides an approach to implement evidence-based practices to address OUD. Multi-sector partnerships are critical to community-engaged research success. Timely data is essential to help inform decision-making. John is a huge resource for Lowell and for Middlesex County in this regard. Communication campaigns are a way to energize communities and can decrease stigma. And there's a great importance of considering social determinants of health, particularly transportation and housing, that can provide stability and access to treatment. And we want to thank the community advisory boards, key government officials, community coalitions, and community partners, and the investigative team and staff. We were supported by the NIH. These are the grants for the 4 states that were funded. And really thank you for your time and attention. And I'm happy to answer any questions here today or via email if anyone wants to follow up afterwards.
Thank you, Doctor. Questions, comments?
I should say I'm a Natick resident, so I didn't include that in my orientation. So I am
That's
a
a good
resident
thing.
of Middlesex County too.
What do you think, Doctor? Do you think that that study will launch again? Do you think it would be useful to do that sort of without the COVID?
I do. You know, it took a lot. It was a real heavy lift to get all of the community coalitions up and running, to then select what were the interventions, or the communities to select what interventions were the most relevant ones that they felt would have the biggest impact. We were kind of building the plane as the plane was taking off, is how a lot of the key investigators try to think about it. I think we learned through the process how to do things more efficiently. And so when we implemented the intervention in the Wave 2 communities, the original controls ultimately got the intervention a couple years later. We were able to do it more effective and more efficiently. So yes, I do think it can be effective in other ways. We saw positive impacts in terms of naloxone distribution. We saw things going in the right direction in terms of decreasing fatal overdose, but it wasn't statistically significant in terms of the difference. I do think that we could learn from the mistakes. We can learn how to be more efficient in implementing and doing it even better. There's a lot here. It's kind of like thinking about the moonshot and what we learned from going to the moon, right? Going to the moon was one thing, but there's a lot of technologies that came out of that too, and a lot of lessons that led to future directions in communications, for instance.
Thank you. Thank you. Carol, do you have a question?
Yeah, quickly, thank you. I'm on a board of health in a small town, but work across 4 towns with prevention, and Natick does great work with Katie Sugarman and the coalition there. My question is, have you connected with the state to use opioid abatement funds? 60% stay in the state, and then our communities get 40. Small towns know we can partner through Mike Hugo and Cheryl and do IMAs to partner on work. But I just wondered, with the difficulty of grants and funding, if you've considered connecting through the opioid abatement funds, because you've done this work and understand what is promising and what works.
We're happy to present to anyone, anywhere that we're sharing some of these data or sharing some data from our other studies could help to inform local decision making. We do collaborate with MDPH and BSAS, Bureau of Substance Addiction Services, on another project really looking at OTP access. We're providing them with results for a data dashboard that they're creating. That the hope is that the data dashboard could help to provide information in near real time that could help to inform decision making related to the abatement funds that are being distributed to different communities. For one of my other studies, is called P2P, Predict to Prevent Opioid Overdose. We're developing models to try to predict where and when we can expect spikes in overdose. As that work moves, we have a community advisory board that includes local and state public health officials, harm reduction agencies, people with lived experience. Our plan is to develop a data dashboard that can create simulations that can show if you increase naloxone distribution or you increase access to MOUD, this is how it will bend the curve in terms of overdose, and have it present as a map in an online system that people can go in and check, different options and see what it means and how they might be able to change their intervention focus to bring about change. So we're happy to present to anybody, anywhere where, data might inform data-driven decisions, and our maps often are helpful in painting a picture for folks. And so through our work with MDPH and BSAS and the Healing Communities team, there have been conversations related to the abatements funds.
Thank you for all you're doing.
Thank
My
you.
pleasure.
Thank you. Thank you, Doctor. Any other thoughts, questions? All right. Thank you all for being with us. Remember, that increase in having Narcan, naloxone out on the streets has been huge. We are happy to give people as much Narcan as you can use. I buy lots and lots, and I like to keep it moving off our shelves. We have as well available for people fentanyl and xylazine test strips. So happy to get those out there as well. So thank you all. Have a great marathon weekend. Enjoy the beautiful weather. Thank you. Take care. Bye-bye.